and welcome to this second Monday of our CLL refresher with updates from ASH. I'm joined by my co-chair, Professor George Follows, and today we'll be joined also by Nick Martinez-Calle from Nottingham and also by Dr. Helen Ma from Newcastle. Over to you, George.
Thank you, Renata. Thank you for the introduction. So for the delegates who were with us last week, you would have seen a fantastic run through discussions about CLL disease biology and also got quite an insightful discussion with our patient representatives who are with us this evening as well. We've got John and Lelia, who must not be referred to as Professor Lelia. I see she's come up. I insisted last week we call her Lelia. So this evening we're going to talk through first-line CLL, firstly with Nick, and then Helen's going to take us through second line. Remember, as before, our presenters are kindly going to try and summarise the world literature as we have it today in about 40 minutes, and then we've got 20 minutes of open discussion. Please put questions into the chat. It really helps us when we're chairing discussion points, and we will of course be bringing in our patient representatives, so we'll have 20 minutes of chat after Nick's talk on first line, and then the same again, 20 minutes chat after Helen's talk with second line.
So yes, it's a great pleasure to be here really, and to be talking about this which is probably one of the most contentious issues currently in CLL, because this is where we've got the greatest bit of recent data, really. So trying to keep it to 40 minutes. I might have to skip a few things quicker than I would want to, but obviously in the interest of time, we try to leave a good time for discussions. So initial slide of my disclosures, and a brief sort of guideline of what we are going to speak up today. I'm not going to speak about the last point very much, because obviously that's Helen's talk, but there are a few points that I'm going to touch and I'm going to introduce really to then allow Helen to elaborate on them quite a lot more. So the first introductory slide is this nice cartoon that shows us the potential sort of a mechanism of action of therapy in CLL, and you can see the block of apoptosis, the B-cell receptor pathway, and now the surface receptor, whether that's CD20 or CD19, which are very well targeted. And we've got now more than one drug, although, for example, in the part of the right-hand side where there is venetoclax, we've got now more BCL2 inhibitors coming our way, and we've got a wealth of covalent, non-covalent BTK inhibitors, and we've got the monoclonal antibodies now, but now we've got bispecific antibodies and soon hopefully CAR T cells. So we've got a varied and wide modality of targeted agents to target CLL, which is very exciting to be honest. So so then the treatment of choice when you are trying to decide what to give a CLL patient is basically down to these two options, and I think that's the way we approach it locally at our MDT, and I think that is the way that we're going to try to put it forward in our on our guidelines that should be reviewed later this year. Whether you decide to go for continuous BTK inhibition therapy, which any of the three agents, and we're going to try to touch into the differences, if there is any, between these three agents, or you go for the fixed duration therapy with any of the venetoclax-based regimens. So I think the most important thing about the current landscape is that that old definition of a FCR feed, BR or chemotherapy, chemoimmunotherapy feed versus non-feed, etc. I think we can agree probably all in this forum that is rather obsolete now. There was some sort of late sort of persistence of FCR in the younger and mutated IGHV population that has been kept historically, but I think we've got now very good evidence on good randomized studies, which includes our FLAIR study, that has definitely demonstrated that even in younger patients, the targeted agents are far better than chemoimmunotherapy. So I think we can now confidently say probably there's little role of it. And we have these two groups whether you've got fit patients or unfit with comorbidities, and although we have to acknowledge this is probably a continuum, there is a slight difference, or a slight binary differentiation in these two groups. The first one is the one that's highlighted there in red, as you can see, which is the traditional, fit patients, which we have trials for against chemoimmunotherapy with FCR or BR, with venetoclax-based therapy. And we have studies that compare ibrutinib with chemoimmunotherapy, but unfortunately, this is BTKs are not approved in this sort of population in the UK. So although we have evidence about this this benefit, BTK inhibitors are not probably available here. So then we will be offering these patients venetoclax-based therapy, fixed duration, whichever you decide to choose. And then for the rest of the patients who are who have data, clinical trial data against chemoimmunotherapy, both for the venetoclax-based therapy and for the BTK inhibitor therapy. So I'm going to try to go one by one to try to show you the latest evidence, updates that have been presented at ASH, and some additional data that might have come up. So let's just fix ourselves in fixed duration first, and let's talk about venetoclax obinutuzumab, which is something that I think most of CLL clinicians will have experience with by now. The latest data, this is not exactly from ASH, but from Lugano, has been presented with a follow-up of 76 months. It's quite long follow-up. And finally, the median PFS has been achieved with 76 months of PFS for the venetoclax obinutuzumab arm. The inclusion criteria of the study are there on the yellow square that you see in the top right, and I'll try to maintain that same structure. So every time I present a trial, you'll kind of see those key inclusion criteria there. And the interesting part of this presentation was to demonstrate for the first time that there's a significant difference in PFS between mutated and unmutated IGHV in favor of those who are mutated, which is something not entirely unexpected. And it's important to know, to put into context these results, because the fact that the unmutated do worse with this combination, because they have a shorter PFS, does not mean that is necessarily a wrong choice for the mutated patients if you decide to go into the fixed duration therapy. It just highlights the fact that the mutated patients do very well with whatever you give them, and then discussions need to be had with the patients who are unmutated. And then there's also the same difference that is maintained with chemoimmunotherapy. But as we go along, and they show different studies which then compare themselves to chlorambucil or obinutuzumab, which is something we now, I can't remember the last time I used it now. It's quite sad to say that, yeah, we should look at this study, and the study was positive because it has compared itself to chemoimmunotherapy. But actually, we probably are looking into the results of the targeted agent and not looking too much at the chemoimmunotherapy, because this is something that we're less interested, I suppose, in now. This is also another a result that has been presented, and very interestingly, the results of the 17p deleted or TP53 mutated cohort that are obviously inferior, as we would have expected for this sort of cohort. But again, they're not bad. And if you had the comparison for the outcome of those patients with chemoimmunotherapy, would be significantly better. So again, maybe it's not the first choice for these patients, but it's just to highlight to the audience that it may not be wrong to choose this regimen for patients with 17p if, for example, you have no way to give these patients a BTK inhibitor because there is a cardiovascular comorbidity that would preclude it. And it gives you an idea of what to expect of this regimen if you give it to a patient with 17p TP53 aberrations. Sorry. the side effects and the safety of venetoclax obinutuzumab in this study, there's longer follow-up, but this is something we were all expecting: the infusion-related reactions and the main adverse events related to the venetoclax, which are the neutropenia and the GI toxicity, and also the neutropenia. The next study, so this CLL14 was looking at this regimen in the older population, and the German CLL study group has complemented this with the CLL13, which is looking at this combination in the younger chemotherapy fit FCR fit population, I should say. These results were also presented. They're very interesting, and there's a lot of things that could be talked about this trial, and I don't want to go and spend too long in this one because there's a lot to cover, but there's a few points, important points. First one is that this study does demonstrate with I think uncontroversial evidence that obinutuzumab is a better antibody than rituximab in combination with targeted agents. And I think that's unquestionable and undeniable, but it is something that we had always asked ourselves, and it is very nicely demonstrated. And then the other question that they've asked themselves here is whether the triplet, so adding ibrutinib to a combination of venetoclax and obinutuzumab, gives them a benefit in terms of PFS and in terms of overall survival, and you can see here there is no difference in the progression-free survival between the triplet and the obinutuzumab and the venetoclax combination. You might argue that this might, with longer follow-up, these curves may separate further, and then the evidence may become, or the difference may become apparent as patients progress, because you agree with me that 4 years is still relatively short for this regimen because the outcomes are so good, and it highlights the need of long follow-up for this type of studies. And you can see, and the other definitive point they have demonstrated is that the blue curve that you can see in that couple of Mayo curves, the chemoimmunotherapy curve, definitely performs worse than the others. So this is kind of the demise of chemoimmunotherapy in favor of the novel agents. They have also looked at, on the right-hand side of the slide, you will see the MRD results. They have looked at some minimal residual disease at a very deep level, 10 to the minus 6, as you can see, and the rates are really high. And another way to demonstrate that probably the triplet doesn't add very much to the obinutuzumab and venetoclax is that the difference in the deep MRD, 10 to the minus 6, is not very significant between them two at the end of treatment, that is. Maybe the triplets may not offer significant advantage. And we have observed a similar difference between the mutated and unmutated IGHV as the one we have observed in the CLL14 study. So in the younger patients, that sort of paradigm of the mutated patients doing very well and the unmutated patients doing less well is maintained with all the 4 different treatment combinations, and in this case, interesting to see that in the unmutated IGHV, the triplet does have a progression-free survival advantage against obinutuzumab and venetoclax, although interesting to see. This is obviously not powered to demonstrate this difference because this is a subgroup analysis, but interesting to follow this up and see if these may be a group where the use of the triplet might offer a significant benefit. The other important pair from ASH is that they have made the exercise of using the MRD status in order to predict the PFS outcomes, and obviously the MRD status significantly improves the prediction and the outcome, the expected outcome, as compared to the IWCLL response criteria. So we're not saying the response criteria is going to be obsolete, but it does make the point that the MRD probably needs to incorporated in the response criteria, because it does give you a very good idea of how long the patient is going to remain disease-free after treatment with a fixed duration treatment like this one. There isn't any significant difference in the safety outcomes. I'm just going to show you, a headliner of all the adverse events and grade 3 adverse events, and then you can see that there's clearly a slight increase in grade 3 and 4 adverse events for the triplet versus the doublet. So again, whether that benefit we're observing only specifically to the unmutated IGHV, difficult to see if it's powered, and with an increase in an adverse event profile, we're not sure if that is something that may be worth using. So then, those are the two bigger studies for the fixed duration venetoclax obinutuzumab. Now we move into the ibrutinib and venetoclax combination, which is the other big group of venetoclax-based therapy. And for this, I'm very pleased to present here the FLAIR study results. I presume many people in the audience have seen this data, but it's quite powerful. As you know, FLAIR is probably the biggest, or nearly the biggest CLL study that has been conducted so far. The results of the FCR versus the ibrutinib combination have already been presented, and it does show a significant overall survival advantage, PFS advantage of ibrutinib versus FCR. And this is the updated result of the ibrutinib plus venetoclax combination. It is important to say that well, most of some of the audience might have been familiar with the trial protocol of FLAIR, in which we had very strict rules for stopping therapy, and patients were kept in treatment for longer than the standard 15 months that has been approved for I+V and that we are currently using. And in fact, only a third of the patients, closely to a third of the patients, actually had 18 months of therapy, which was the bare minimum that they could have. So with that caveat, and you know, that because of this is not yet fully applicable to our practice because we use I+V in a different way, the results are very powerful because they not only shows a significant progression-free survival advantage, as you can see, but it also has shown a overall survival advantage with the MRD-guided treatment with I+V, which is really hard to demonstrate in CLL, and I think it's very important. So it was very welcome, this result at ASH, and it generated a lot of valuable discussions. Again, interestingly as well, as compared to other ibrutinib plus venetoclax data, we will see there isn't any significant difference yet, perhaps, versus the mutated and unmutated IGHV on the patients who were treated with I+V, and that probably speaks to the value of this MRD-guided approach, and has given us a lot of strength in the CLL sort of NCRI subgroup to try to pursue some research that is pointed at clearly demonstrating this against the fixed duration 15-month that is currently approved, and able to convince the regulators and etc. that this is probably the way we need to use I+V, and trying to find a way to use it. And then we, because the way we have established the treatment duration in the FLAIR study is not necessarily the most easily applicable to all sort of clinical scenarios, but the hazard ratios here are continue to be quite significant, and it also demonstrates that the FCR treatment, as we know, is very good for the mutated patients. But even though it is good, the I+V has shown superiority, although it's still not statistically significant. And this is another part of the presentation, which is very interesting, and I thought it was quite illustrative of the fact that the traditional risk, sort of cytogenetic risk factors that we have considered for FCR probably are no longer applicable for the novel agents. And I thought this slide was probably the best example to showcase that. And as you can see, the traditional ATM11Q deletion and the trisomy 12 and the 30Q deletions are, they don't really apply anymore for these novel therapies. And we should be looking into ways to redefine this risk groups, because we ran out of good evidence to use them, I think. The adverse event profile of both arms, not surprisingly, you can see on the third line there, increasing cardiac disorders. So that's related to sort of atrial fibrillation and routine-related issues. Interestingly, the risk of secondary malignancies, as these patients have been followed up for quite a long time, and it does demonstrate also or reinforces the fact that we should avoid using FCR in favor of these because of the risk of secondary malignancies. As you can see, a number of not only skin cancers but also other hematological malignancies is quite high, with an incidence rate that is nearly double the one of I+V. So very important to highlight that and see data on a more recent trial with young population, as you may remember from the original publication. Quite important as well. And then the other update from an A+V cohort, which this is a slightly different study because it included patients below the age of 70, so not necessarily all so FCR fit, and it has also allowed patients with 17p and TP53 abnormalities, so slightly different population to FLAIR, so do not compare it directly, but showing 5-year follow-up. Showing that the unmutated patients do quite well, as similar as the sort of general cohort. And I don't have the mutated IGHV. They didn't show the mutated IGHV curve, so I won't be able to show. But presumably, it shows a similar trend as the one that has been seen in FLAIR. Again, significantly high rates of undetectable MRD that you can see on the right-hand side of the slide, with the green bars showing nearly 60% of negative MRD with a fixed duration MRD of 15 months, and significant impact on PFS of those patients who achieve MRD negativity versus those who don't, with a significant time to new treatment difference in between those two groups. And I'm going to briefly touch on this. I don't want to go into too much detail because I think this is more pertains more to Helen's talk. But one of the main aspects that has been presented is an analysis of the patients who have already relapsed after I+V in the cohort of Captivate study, and showing to us what the features are of that relapse and what treatments have these patients had. So a headline essentially has demonstrated that for these first few patients, there is still good sensitivity to BTK inhibitors after I+V based combinations, and venetoclax or ibrutinib plus venetoclax retreatment. Some of them have had it. So very slow numbers, but very significant data as well. And the other ibrutinib plus venetoclax combination has been presented by George in this last ASH, comparing ibrutinib venetoclax versus clorambucil in the sort of older and comorbid population, and again above 65 years of age, or CIRS scores above 6, but excluding those who with P53 abnormalities. Again, 100 and plus patients per arm, and you can see obviously we would expect a significant PFS difference. I think there's no surprise to that. Quite importantly, the MRD rates are very similar, so it's 54% of 10 to the -4, and the rate of 10 to the -6 MRD, as you can see in the red bar, is quite high as well, 43%. So very good results in terms of efficacy, with similar separation between mutated and unmutated IGHV. This is interesting because as you remember what I've showed on the flare data, this difference seemed to be a lot less for the flare study, and again inter-trial comparison, etc. But it is interesting to and I think hopefully this will serve to also demonstrate to the regulators in the future that if you cut the treatment short at 15 months, then the mutated IGHV patients might not benefiting might not having as much benefit as we think they would if they had an MRD guided approach. So the follow-up is now 54 months, as you can see, and the difference is quite striking in MPFS as it has been demonstrated for BENOV, for example. So again, but again, I suppose relevant to mention as well, not necessarily a reason not to give ibrutinib and venetoclax to an unmutated IGHV patient. It means that you know what to expect from it, but it doesn't necessarily mean that this is not a reason to do it. The overall survival is interesting to analyze. There's been a lot of debate about this, as you can see. The overall survival is excellent, but there's an initial drop-off of survival, as you can see there in the first year, and that's during treatment, actually. There's a few deaths on therapy that have been debated at length, and this is an analysis, specific analysis on those deaths. As you can see, most of them are cardiac or sudden deaths or unknown deaths, which we presume could be cardiovascular related deaths. It's a relatively small study, so a few events in a cohort of 100 patients will have a significant impact on the curves, and that has to be taken into account. On the other hand, it is a signal, and it is strong, I think, and we think it's strong enough to at least caution people to carefully select patients who are going to ibrutinib and venetoclax. Those who have treated patients, those of us who have treated patients in flare, know that I+V does have a slightly more adverse event, and the adverse event profile is slightly worse as compared to ibrutinib on its own, and people, on the 60s, they do struggle with ibrutinib and venetoclax, and I think we would all agree that you just need to pick your patients very carefully. There's also an insight from the study, and that has shown that most of these events occurred in sort of Eastern European countries where the access to other novel agents may not be great, so people might have been put into clinical study with slightly more, and the care of these patients might not have been equivalent to the care they would have had in Western European countries. So there are a few things that are unknown about this, and it's just a word of caution in the end. So I've got slightly 15 minutes to go through the fixed duration to continuous BTK therapy. So a few conclusions for these fixed durations. So we think the PFS outcomes are roughly comparable to the continuous therapy. We'll look into that a bit later. The time of treatment might be relevant to many patients. That is important to highlight that, because this is a time off therapy and off side effects, which is quite long. We need to highlight the high rates of MRD and the role of the MRD guided approach, which is we hope that we can manage to incorporate that into routine practice, although it might not. It might have to be might be slightly different to what we have done in flare, but there has to be a way to do it. There seems to be a difference in IGHV mutation, except for the MRD guided approach, and we'll see if that is another reason to sort of advocate for it, and the concerns from I+V in the older population. So this is what we would do in an algorithm, and I'm going to move it slightly quickly, but again, there is some evidence that you can repeat venetoclax-based regimens, but ideally you would want to change mechanism of action if you can, particularly if they progress on therapy or the progression is close to the end of therapy, whereas if they have a longer PFS, then you might want to consider venetoclax again in a different regimen or continuous. I'm not going to go into, in the interest of time, into much detail about this algorithm, but there are a few question marks. Again, what to do with the unmutated IGHV, and specifically for the TP53 aberrant, whether it is reasonable to start with venetoclax-based regimens or not. And my answer to this would be maybe yes, because these patients will then cycle quickly through therapy, and they will have BTKs later, and we don't know yet if that is equivalent, but we hope to gather data about this. And then the venetoclax plus the CD20 antibody, very important to consider in people with autoimmune phenomena, because the obinutuzumab is also a very good sort of B-cell depletion antibody, and that's probably my choice in patients with autoimmune hemolytic or ITP. So 10 minutes to go through the BTK inhibitor therapy. As you know, we got now 3 agents, and the question is how to choose what to do. So you now decide, you go through, you're going to go with continuous therapy. You decide you want to go with a BTK, and you've got a choice now. So what do you do? Zanubrutinib is the one I'm going to present first. As you know, the Sequoia study has compared zanubrutinib against bendamustine and rituximab in a randomized fashion, large study again, registration study. And again, big difference against BR, but that's not necessarily expected. So maintain that number in your retina, so 82% PFS at 42 months is what we would expect with zanubrutinib. The feature of the BTK inhibitors, as opposed to the fixed duration therapy, is that there is no difference, or hardly any difference, between mutated and unmutated IGHV in terms of PFS, as you can see in this curve. So the light and the dark blue curves, they're very, very, very similar, and that's a feature that has been maintained throughout the BTK inhibitor studies, as you will see in a moment. And the safety of zanubrutinib, nothing really unexpected to the known side effect profile of the BTK inhibitors. Rates of bleeding, hypertension, atrial fibrillation, significantly lower. That last one of atrial fibrillation, which may be relevant for the treatment choice between BTK inhibitors. Probably the BTK inhibitor with the lowest rate of AF so far, although follow-up slightly shorter than the other BTK. So we'll see if that plays out to be continues to be lower with time. The RESONATE-2 trial, although we don't have access to ibrutinib in frontline study, so I wanted to show these results for 2 reasons. Basically, because it's the longest follow-up we've got on a BTK inhibitor, 8 years now, showing a median PFS that's not yet reached at 8 years. So so excellent numbers for BTK inhibitors that we'll know. But this is a paper from a few months ago, but it does showcase and highlight that the adverse events in BTK inhibitors continue to have ongoing incidence as you go along in treatment. If you go to after 5, 6, and 7 years, which you can see in the sort of in the green, grey, and red bars, you can still see incidence of hypertension, AF, hemorrhage, and all the other sort of relatively minor side effects throughout the later years of therapy. So really relevant to highlight that if you're on continuous BTKI, yes, you have good clinical outcomes, but you have ongoing sort of adverse events. The final BTK, acalabrutinib, coming from the ELEVATE-TN study. So 6-year follow-up was presented at ASH, which 2 things to discuss importantly. So the median PFS is 62% at 72 months. If we, it's quite longer than the zanubrutinib, so difficult to compare head to head, but probably is following the very similar trajectory. But the really important point here that it's a shame we can use is the combination of acalabrutinib and obinutuzumab. because it has shown now clearly progression-free survival benefit against acalabrutinib monotherapy. Now with good statistical significance and long follow-up, etc. So it is really interesting, and we think that, sorry, I hit this slide, but we think that the benefit is mainly driven by improvement of the PFS of the patients who are TP53 aberrant. There were a minority in this study, but if you look at the different cohorts by TP53 mutation, then you will see that in the acalabrutinib plus obinutuzumab, this cohort had a significant benefit compared to those who were unmutated, so or naive. So really interesting. Obviously, I don't think we'll ever have this approved in our, I don't know if we'll ever have this approved in our country, but if you do private practice and you're able to use it, then it is a great option, and it gives you the possibility of using obinutuzumab in the front line with a BTK inhibitor, because if you don't use it with a BTK inhibitor, then if the patient relapses, then the possibility of using obinutuzumab at relapse doesn't exist. So also an interesting point to make. Quick headline of the summary of adverse events from these three arms, which basically show a slight increase in adverse serious and grade 3 adverse events from the combination. But I think it could be argued whether or not that outweighs the benefit of the PFS, particularly for the TP53 aberrant. I think they probably do, but obviously would expect a little bit more side effects in terms of neutropenia and infusion reactions, etc. with obinutuzumab. So here they are. So the three drugs compare head to head, and just the headline is that on the basis of efficacy, there's very little we can say to choose one or the other. I'm afraid is impossible. So those who were waiting to hear me say, for these patients you can choose this, and for those other patients you can choose this other one. I'm sorry to disappoint, but I don't think we've got evidence to choose one or the other on the basis of efficacy. So is there any subpopulation in which we can choose one above the other? So I just went into a little bit of detail and trying to tease out if there is, for example, in P53 aberrant population, if there is any evidence above one better than the other. So this is the data from ibrutinib. This is the longest follow-up study of a BTK in TP53 aberrant population. And you can see the 6-year PFS is not bad, 61%. And the overall survival is nearly 80%. So it's very good data for TP53 aberrant populations. If you remember how these patients did with chlorambucil or FCR or BR, then this is unbelievably good. There's still 18% of patients of these cohort that are still on therapy after 10 years, P53 aberrant patients, remember. And the median PFS is 81 months. So excellent data. There's a long follow-up of this. And this is something that can only be done with the NIH. This is the NIH study. So this is barely the only institution in the world that will have the luxury of following this small cohort of patients for such a long time. So it's very exciting and interesting data they presented. And more importantly, mutations in BTK or PLC gamma 2 were detected in 83% patients at the time of progression. So it also sort of, in a nice way, demonstrated that the continuous pressure of the CLL clones with the BTK inhibitors will invariably make these mutations arise. And this is something that is important to know, and is important to wait when you offer continuous therapy to a patient with CLL. Then what happens with acalabrutinib? This is the graph I was alluding to before. It demonstrates the benefit of the P53 of the acalabrutinib and obinutuzumab for the P53 deleted patients that you can see in sort of the dotted blue curve, and the virtual absence of difference in the acalabrutinib monotherapy, which is what most of us can use at the moment. So there is no benefit for the use of acalabrutinib in the P53, and the curves do look very similar to what the ibrutinib curves look like, maybe slightly worse. but I don't think we can draw a neat cross-trial comparison here. And for the zanubrutinib follow-up is much shorter, 42 months, but the value is 79%. So if I quickly go back down, and if you follow the 42-month line up, then you can see it's not very different from zanubrutinib. And what about IGHV mutation? Then I think both of so 3 of the agents we've discussed have shown there isn't a great difference between mutated and unmutated with long follow-up. So I don't think the IGHV mutation is also going to help us to choose one BTK inhibitor or the other. So again, nor the p53 nor the IGHV can help us. So the likely differentiating factor for these is going to be the side effects. And I was going to talk long and long about this, but the real data we have to compare the efficacy head-to-head, rather than just getting the safety data of each individual trial and try to compare it, which is not really fair, is the relapse studies which have compared both acalabrutinib to ibrutinib and zanubrutinib to ibrutinib, which I will leave Helen to discuss, and maybe just point out one thing I think is really key. So I'm just going to skip this. I'm going to leave that's the bleeding risk. So the bleeding is very similar in between all the 3 BTK inhibitors. It's been calculated, and is about 3.4 per 100 patients per month for ibrutinib and 3.26 with zanubrutinib, so maybe slightly less. The point I'm trying to make here with this slide is that we know there's a bleeding risk with BTK inhibitors, and there is an inherent bleeding risk with the use of antiplatelets and anticoagulant agents, and there is very little data about what is the risk between with the use of BTKs when you have to give patients anticoagulation, and this is something that is missing. And we need more data about this. But there's been several studies, case control studies that are imperfect, obviously, but to me has been very enlightening to them, that they seem to have demonstrated that the risk of ibrutinib in combination with novel anticoagulants or DOACs and the risk of ibrutinib of those who are anticoagulated with low molecular weight heparins, and it seems that the low molecular weight heparins have significant higher risk of bleeding as compared to the DOACs. So this is very enlightening to me, because if you're going to choose to anticoagulate a patient with BTK, is probably your best and safest option is to use DOAC. And I'm gonna skip through all the comparison of adverse events, because in the interest of time, but just mention that obviously Zanu and Acala have a more favorable profile than ibrutinib. I think that's clear, particularly in terms of cardiac safety. And in terms of infections and diarrhea, zanubrutinib looks a bit better. The bleeding risk remains similar, and that there are studies that have looked at the switch of one BTK versus the other. All of them have been done on patients who were on ibrutinib and went into either acalabrutinib or zanubrutinib. But it is interesting that those studies have shown, some of them were presented at ASH, showing that in nearly 2/3 or 80% of the patients, the adverse events do not recur when you change patients to the other BTK. So message here is, before you decide your patient is intolerant to BTKs, maybe it's reasonable to try to switch to a different one and see if the side effects recur. And again, much research needed regarding anticoagulation, etc. And this would be the treatment algorithm that I stolen from Lisa Roker and Anthony Mater, but I think this is probably the way that the world is going to go. Either venetoclax rituximab in progression, or they're intolerant, try to switch, and if not, change to venetoclax rituximab. I'm going to leave it there in the interest of time. So thank you very much for your attention.
I think, why don't we leave comparative BTK discussion, I think, to when Helen talks about the relapse setting, because I think you've put out a very clear case that in terms of efficacy, it is quite hard to say A versus B versus C. I think they are separated in a number of different ways from an adverse event profile. And of course, we're going to gradually build our experience, particularly with zanubrutinib, which has recently come available. So we can leave that discussion. Let's dive straight in. I+V, that was clearly the chat at ASH, and what an amazing presentation from Pete Hillman and the UKCLL group, and simultaneous publication in the New England Journal of Medicine. So that really raised the profile of UKCLL research as well, which is fantastic for everyone. I think you kindly mentioned I presented the GLOW trial, which, to recap, was older patients, less fit, shorter duration of therapy. And I've been involved with various discussions since ASH. Of course, I+V is controversial. It is not an approved therapy in the US, as Bill Weirder reminded us. And although we're not US doctors, so we don't know the details, there have, of course, been a slight difference of interpretation with the FDA and the company and what data has been submitted. And we understand this relates around some of the adverse event profile in the GLOW trial. But I think a first observation from FLAIR, these were younger, fitter patients. And I think we have to remind us that most of us in the UK have most of our I+V experience to date with these younger, fitter patients. But just like Captivate, we did not see the early mortality. And I think you talked to that point, didn't you, Nicolas, that early mortality in the GLOW trial does seem to be a bit of an outlier now against the two other trials.
Yes, yes, like I said, it is, it is a 100 patient per cohort study, and if you have, even if you had, 2 or 3 events, then that would be, it makes a big difference in this, smaller percentages. So it's hard to definitively conclude when you've got 4 or 5 events in 100 cohort of patients, obviously, because but it does show that the selection of these patients might not have been appropriate, and they may have previous comorbidities that have put them at risk of problems with the ibrutinib-based therapy, and just statistically, obviously, these comorbidities will be a lot more common in people who are above 70 years of age, and therefore, something to consider. It also dwells a lot into the patient's sort of previous medical history and past, and so important to consider that aspect as well.
And I think it is. So I've been on the writing group with the GLOW trial from the beginning. And so seeing, as you pointed out, there were some pretty frail patients put in that trial. And I think we've all become much more aware of ibrutinib, the cardiac toxicity, the care we have to take. So we're going to choose the right patients. But I'm going to give you 2 reflections that have come to me in the various meetings I've been dragged into post-ASH. So number 1, even with an older, perhaps less fit patient, if you accept mortality up front, if you say there's a statistical risk, but you want to have that long plateau, you as a patient, age 75, might say, well, okay, I've got leukemia. I'm going to turn this around a bit. I'm going to accept a 10% first-year mortality if I've got a chance of staying in a flat plateau and having an 85% or 84%, whatever the GLOW trial is, survival at 5 years. So that's just one reflective philosophical comment, which caught me a little bit on the hop, because I thought, yeah, okay. And then another comment which came from my American colleagues is, we in the UK are very proud of FLAIR, which of course we are, but of course at the moment that is a continuous therapy trial, because FLAIR has got 42 months median follow-up, and I think it was pointed out to me that 48%, so some chunky percent of FLAIR patients have over 3 years of I+V. So within the median follow-up, actually, we're looking at a continuous therapy trial, which shows us, I'm being really cynical because this was being pushed on me, that actually I+V continuous up to 6 years is great therapy. Now let's get it. The MRD is allowing us to give extended therapy for perhaps the more tricky patient and cutting them back to 2 years for the better risk. But I don't know, Nick, before I bring in anyone else, any philosophical comments or thoughts on what I've just said?
Yes, it's the key to the question, really, and I think I think the FCR does dwell a lot into the details of disease biology, and it feels like a continuous therapy because some people will be on drug for a long time, and therefore the treatment-free period discussion then goes out into play. But I think philosophically, if you put that idea to patients, probably, and it would be interesting to know what they think, if you're guaranteed to have such good outcomes, even if you're going to be in drug for longer, I don't think that necessarily would be something that, from the patient perspective, would be entirely unreasonable and necessarily rejected as a patient. I don't know what you think.
Well, I mean, let's go straight to John. We'll pick on John. John, is he on camera, or Lelia? Which of them first gets their camera on? They're probably just relaxing, thinking they're not being dragged into this discussion. So, John, philosophically, that whole principle, if you're... Oh, Lelia comes on camera first. There you go, Lelia.
I think, give John a minute or two. I think last time he just had a problem getting his camera switched on,
there is
George.
a minute or two. We've got so much to pack in. Lelia, tell me, as a patient, if somebody said you're on fixed duration I+V, but it ends up being a 6-year course of treatment, would you still approach that from the benefit of thinking, okay, well, this is a package of care I have to have delivered, then I'm off it? Or by then, are you just resigning yourself to this is just ongoing therapy?
I think some of these distinctions are very clinician-facing. I think at the time, probably most people, I mean, everyone will have different values about whether they prefer something that's shorter term that then gives them a break with something longer term. And some of that will be their personal preferences. Some will be their, whether their family and work commitments if they're younger folk. I think the thing that you said at the beginning, I would absolutely emphasize. I think it's great. When I was diagnosed 15 years ago, there was very little choice. It was FCR or nothing that I was offered, and that was no choice. But I think these choices should be carefully explained. I think there's now a real case for shared decision-making with people with CLL at the point, and well before. I mean, my experience is that it's not a crisis when you come to decide to need treatment. There's a period during which, your bloods are going off, to put it in a layperson's language, and there's a series of discussions that happen. And that's the time to explain to people, to point them towards good sources of information, to explain why the trials, and hopefully some good systematic reviews of the trials could help them make that decision between the balance of the benefits and the risks, the harms and the benefits, because people will also have different views about different sorts of side effects. I've got a friend who can't tolerate nausea, so anything that gives her nausea would be a no. So even in terms of what side effects they are, people will have different values.
I think as I bring John in, we had explored that last week, didn't we? That sort of negotiated start point. And our job as clinicians is to help translate clinical trial data into language that the patient you're sat with can understand. And actually, it's quite interesting, the distinction, fixed duration and continuous, that we as clinicians come away from a conference and feel most fired up that everyone will want this or everyone will want that. If we actually give patients an honest voice, quite often they go against what we think. And taking a step back, all of our CLL therapies are very effective for our patients. So it is hard to point at one and say it's a mistake. I'm saying that just carefully. But John, you've heard this discussion. Let's bring in another patient view.
I would say that, and it's a mantra that we have emphasized, is an informed patient will have a better outcome. So if the patient has had that time to get up to speed with the various options that are available to them, then they're in a better position to be able to take that decision in their own time with the guidance of their clinician. And of course, like here in Scotland, for instance, venetoclax as a single agent is a continuous therapy. It's not time limited. So, that's a jurisdiction difference, just across the border. So that's an interesting dilemma as well.
Thank you, John. So, Renata, I'm going to bring you into a bit of discussion because I think we've had that discussion about fixed duration, about continuous. We've heard a bit about the debate about different subgroups, and Nicolas was very careful to point out that, giving an unmutated IGHV patient a fixed duration therapy isn't wrong. Of course, you accept that relatively their PFS is lower, but if you get a 4, 5, 6 year remission from your first block of treatment, that might actually fit the package of care that you're planning strategically with that patient who might be, 70, 72, that might all fit. But Renata, I think a more difficult question for us in the clinic is a fixed duration deciding between venetoclax and obinutuzumab and venetoclax ibrutinib. If you've got fit patient, they've got no cardiovascular risk, they're 62, it isn't always easy in my experience. I'm discovering that. Renata, do you have views on this? Anything guiding your decision making?
Yeah, yes. I mean, if it's a fit patient, obviously venetoclax and obinutuzumab been around for quite a long time, and we know that especially for mutated patients, it's a very, very good option. So so I want to have all the information. I want to have a mutated status and TP53. And if the patient is mutated, for me, default option, I'll usually start from VO. I must say, with the way the information, obviously, which was given, I plus V, confused me slightly during ASH, because I thought I plus V, fantastic, amazing drug, probably amazing combination for unmutated and TP53 deleted. And I was very, very unconvinced, which is basically just through because I thought we've got it sorted. No, hardly any. So like the data was showed for in GLOW for those elderly patients, unfit patients, I plus V is certainly not a choice for unmutated patients, because we saw the curves, what Nick presented. The TP53 data we've seen by Paulo Ghia. I mean, there were only a handful of patients, so we can't make a decision. And the other thing, what Paulo Ghia was saying kind of during the questions, that maybe a triplet therapy would be the way to solve those P53 deleted mutated patients, if we can get them into undetectable MRD. But we're nowhere near. I mean, obviously we need to go to the regulators to try to get I plus V as given like FLAIR, because I think now I'm conflicted when I'm offering I plus V, because I know I cannot give a longer 15 months. And we all know that 15 months, even for mutated patients, is just not enough. And it's frustratingly that obviously they picked 15 months completely plucked out of the air, probably because just to make it good rival for VO. So it's kind of similar time. That's probably, there was probably no good basis of that 15 months. It's just, okay, 3 months sort of to reduce the tumor lysis risk, fair enough, and then 12 months. So you've got, so yes, I've got to say, I plus V, I thought was before ASH, I thought was a savior for me. No, VO is still a default for me now, and I plus V, I think, for young, very fit patients. But I think I would like to hang on till we can give it for longer.
And I think, so I take your points on board clearly. I think observational comments, so I plus V does seem to drive these unmutated IGHV patients into MRD undetectable remissions. And in fact, the strange quirk with I plus V is that more of them get deep remissions than the mutated IGHV. But the inescapable fact that we saw with GLOW, that when you follow those patients for 3 years, half of them lose that remission. So although I don't normally get too stuck in discussing MRD, I think in this circumstance, the difference between the mutated IGHV and the unmutated IGHV is quite stark. And I think we do have to follow FLAIR for longer, because it is still entirely possible that those patients that get 2 or 3 years treatment in FLAIR, well, give them another 3 or 4 years. Beyond that, those curves will start dropping off. There's unmutated IGHV. Basically, if it's not under a constant treatment pushing down the clone, it does give this impression of springing back. And I think in defense of V plus O, venetoclax and obinutuzumab, if you look at the unmutated IGHV curve, you know, they're not that bad. And if you look at Captivate, young fit people, well, their 54-month PFS was 70% with I plus V. Again, so the curves are dropping off. So I think, like you, Renato, this is one of the reasons why I put the question to you, because actually it's not easy, is it? And I think the sat with the patient in front of you, they soon detect when you genuinely have a pure choice. So you find yourself saying, well, one of them's got infusions, one of them's got tablets, one has arthralgia, one has a bit of a sickly tummy, and you start sort of listing things, and you find that we haven't helped our patients. Now, a lot of interesting debate. There are questions coming in the chat. I did warn that these things can go for a long time. They're sequencing questions. Gavin has asked more good questions. He was asking them last week about, should we really be looking at PFS2 to gauge the role of sequencing? You're right, Gavin. We need to get a young, brand new appointed consultant to take that one on, because it's going to take them 20 years to get some robust data. And we do need real world data sets to fit with that. T53 question about patient with ischemic heart disease, a recent PCI, dual antiplatelets. Oh my goodness. Dual antiplatelets, I'd give them Veno.
I would, yeah.
I'm nervous about that. Yeah, Nick, come on, help me out with some of these.
Yeah, I think,
okay.
I think, like I said, I mean, I've shown data for I+V and data for venetoclax obinutuzumab in P53 aberrant patients. If you truly have a contraindication for BTK, I don't think you should be afraid of offering a fixed duration therapy. I mean, you know what to expect of it, and you probably are going to expect slightly shorter PFS. But then you know, in that situation, dual antiplatelet therapy, etc., you're putting your patient at harm's way with a BTK inhibitor, and I've seen, I have seen very significant bleeding complications with BTK inhibitors, spontaneous retroperitoneal hematomas, splenic hematomas, spontaneous splenic bleeding, etc. So, that's a big consideration. If you can't use BTK for whatever reason now because the patient has got a recent PCI, then it's absolutely not wrong to go the other way.
Yes, and I think you did highlight that the differences in bleeding risk between the different BTK inhibitors was marginal. I'd be nervous about saying, BTK X might be better than Y with a dual platelet. Get pretty nervous. Now, before you go, Nicolas, because I'm going to put the quick answer question for you, and then on to Helen. I'm going to give her one question before she starts treating. So, for the unmutated IgG, first line, is it better fixed duration or continuous? So we were touching on that, but I think that's a good one for you to finish the first line. How much does it influence your practice, in honesty?
I think for the unmutated, I'm going to answer the question and then make one final remark. So for the unmutated patients, I think personally the unquestionable evidence shows that if you're treating a patient who's on the late 70s, for example, if you look at these PFS curves, it's probably highly likely that at least a third of, if not more, of your patients you treat in that age group will require only one therapy throughout their lifetime. So then that takes the pressure off of saying we're just going to be the best one to choose now, because then, so from that point of view, I don't think I'll be biased in that situation. Whereas for the younger patients, if you think about an unmutated, then it also takes the pressure off, because then if you use fixed duration therapy, the patient will eventually go into continuous duration regimen, because they will eventually relapse. And if they're young enough, if you go through with the BTK, they will still relapse after so many years. So it's likely that they will also cross and then have a fixed duration therapy further down the line. So so I try to take pressure off myself and think, if for the younger, they might change treatments in the future, and for the older, actually, whichever you choose, the efficacy is so good that that they might not require more therapy. And the two final remarks, as you probably mentioned before, the consent process is now taking probably 2 or 3 different consultations.
Yes.
And it's very important to keep that going and not try to just quickly, get the patient, decide they need treatment, and bring, quickly run through the treatment options and say, what would you think? Because I think that doesn't do the patients the right service. So I think you should explain the options, you give some information, leave the patient a few weeks or a month or 2 months to have a think. And thankfully, we see the patients coming into therapy and coming into fulfilling treatment criteria, and we hardly need to make a snap decision about therapy. So I think getting the patients well informed before. And what's happened to me is actually what you put your options on the table, and the actual the patient goes back the following consultation, they've made their minds up pretty well.
Yeah, no, those are all very good points. I think, can I just observe that your discussion, though, between the mutated and unmutated, you diverge towards talking about younger people with a longer actuarial life expectancy, you're drawn towards fixed duration, and older people with an actuarial shorter life expectancy, you're drawn towards continuous therapy. And actually, maybe IGHV isn't really influencing that decision at all. And I suspect if a lot of us are honest with our practice, that's probably where we end up. We have a lot of chat about IGHV, but actually, I think we're sort of seeing a whole package and trying to strategically map out years to come and where it's easy to see things. I probably putting words in your mouth. No, Nick, I do apologise. I'm having to keep this moving. So, but Helen, before I introduce you for your talk, because the last question is a difficult molecular one, which I have been caught out because I have answered this saying, well, surely there's no reason. You'd have seen this in the chat. Should we be looking for BTK mutations before lines of therapy? And I'm going to interpret that all lines of therapy. Would you even screen someone before you start? So are you able to answer that before you give us your presentation?
I think it's a really good question. I certainly wouldn't be looking before we start treatment. We'd be looking at first line treatment, because we'd be looking about P53 and IGHV status. I wouldn't be thinking at that stage about BTK mutations, because I wouldn't expect the patients to have them if they've not been on the BTK inhibitor. But I think when we're looking at treatments down the line, if a patient's been on a BTK, I think it's a good question, and we would probably routinely do that as part of a sort of lymphoid NGS panel, looking to see if people have acquired a TP53 mutation, and as part of that we would see whether there have been acquired mutations in BTK, and I think it's very relevant in terms of thinking whether they're likely to be susceptible to covalent BTKI retreatment later down the line. So I think it is a good question when you're thinking about retreatment in patients who've been on a BTK inhibitor.
Yes, I think I would go for that. For the retreatments, I can definitely see it. And I suspect we're going to be more strategic because we know that different non-covalents and covalents seem to have a different profile of BTK mutation, which is likely to start affecting us. But I've been caught out once before, being told apparently you can get spontaneous BTK mutations in CLL before you've even started treatment. So it was news to me as well, Helen, but I've been reassured. Now, Renata, let me bring you back in. I can't see. Are you on camera somewhere? So,
yes,
Nicolas,
yes,
thank you very much, Nicolas, for your brilliant first-line presentation. I'm going to hand over to Renata and Helen to take us away for the second part of this seminar. Thank you.
So thank you very much. I'm Helen, and I'm going to talk about the treatment of relapsed CLL. And then when Renata was putting together these titles, she put in this innocent extra bit about the old chestnut of sequencing, which sounds very innocent. And then obviously thinking with regard to ASH 2023, if there are any new data to help our decisions when we're thinking about how to treat relapsed CLL. So I'm going to try and take you through sort of three main focuses. First of all, what drugs do we have available? So when we're thinking about relapsed CLL, what could we use? And there'll be a lot of overlap here with what Nick's already talked about in terms of what we have available in treatment-naive CLL patients, but with a few little minor sort of things to bear in mind in the relapse setting. And then the old chestnut about, is there a right or wrong order in which to use them? So this question about how should we be sequencing things? And then a few sort of future possibilities. So just highlighting a couple of things from ASH in terms of future possible drugs. And as we go along, if there are relevant up-to-date new data from ASH, then we'll stick those in as well. So first of all, what drugs do we currently have available in the relapsed CLL setting? So just as we've already heard about and won't come as a surprise to you, we're talking about these two main classes of drugs, the BTK inhibitors or the BCL2 inhibitors. And when we're thinking about the BTK inhibitors, as we've heard about already, we've got acalabrutinib, zanubrutinib, or ibrutinib available to us in the relapse setting. I've deliberately put ibrutinib at the bottom of the pile there, because as Nick has already alluded to, and we'll look a little bit more about the toxicity with these three different drugs, many CLL doctors now would tend to choose the other options over ibrutinib because of an improved safety profile. When we're talking about the BCL2 inhibitor we have available, really the only one we've got available in this space at the minute in the UK is venetoclax, when we're talking about in an NHS setting. There will certainly be trials coming with alternative BCL2 inhibitors, and I should think we'll be seeing those in the UK this year. And certainly data was presented in ASH about some alternative BCL2 inhibitors, but what we have currently is venetoclax. And we can either use venetoclax in the relapsed refractory setting, either as monotherapy, in which case it's given continuously, or venetoclax given in combination with rituximab as a fixed duration combination. And just to mention that the BTKIs are always in relapse, we're giving them as a continuous monotherapy. Now, I have just included PI3 kinase inhibitors there. They're deliberately smaller and in paler font because we're always going to choose the BTK inhibitors or the BCL2 inhibitors over the PI3 kinase inhibitors. When we're talking about PI3 kinase inhibitors, specifically, we're really talking about idelalisib, which we can give in the relapse setting in combination with rituximab. And I think when you've run out of options and you're casting around for something else, it is an option and it can work in patients who've already been exposed to these two other classes of drugs. But I'm only going to sort of show you very minor data about PI3 kinase inhibitors as we go along, and you'll see that the PI3 kinase inhibitor always does worse than the other targeted agent on the slide. So we're never going to choose it as our first option. And then at the bottom, chemoimmunotherapy with a big red cross on it. So Nick has already told you, we've seen the data from the CLL13 Gaia German group study in frontline CLL, that chemoimmunotherapy now really does seem to be dead in the water in treatment-naive CLL, and that's been the case in relapsed refractory setting for a number of years, because when chemoimmunotherapy is compared with these targeted agents in the relapse setting, chemoimmunotherapy always comes out worse. So chemoimmunotherapy has been a goner in relapsed CLL for a number of years, and I wouldn't recommend using it in any setting really in relapsed CLL. So we'll start with the BTK inhibitors first, and obviously you've heard a lot about the BTK inhibitors already from Nick in the frontline setting, but here we're focusing particularly on the data in the relapsed refractory setting. We'll start with ibrutinib, just because that's obviously where it all began, and so it's relevant to kind of point out the data that we have. And you can see this is quite an old study, and this was a 6-year follow-up, and it was published in 2019, and this was the RESONATE study. So this is where it kind of all began for ibrutinib in relapsed CLL, compared with ofatumumab, a monoclonal anti-CD20 antibody that we don't use. And obviously we would never really use it as a single agent anyway, so not a great comparator arm. But what we're really interested in here is seeing that ibrutinib in these quite heavily pre-treated patients who had a lot of chemoimmunotherapy lines before, because this was prior to all these novel targeted agents, with a median progression-free survival of 44 months. And that was reflected in the right-hand panel here as well, in the genomic high-risk population patients as well. And one of the important things, and we've already sort of alluded to this in the treatment-naive data, but in the relapse setting in this RESONATE study, really importantly, we saw that the IGHV status didn't affect the progression-free survival. So as you've heard earlier this evening, and you'll have heard last week, we know that the IGHV status in CLL is important in terms of prognosticating response to treatments and outcome, and that the unmutated IGHV patients tend to have poorer outcomes. But in this RESONATE relapsed refractory study, the IGHV status did not affect the progression-free survival. And we'll see that as we go on in other BTKI studies. So moving straight on to acalabrutinib, and we're talking about two main studies in acalabrutinib in the relapsed refractory setting. So first, the ASCEND study. And here acalabrutinib was compared with physician's choice of either chemoimmunotherapy with bendamustine rituximab, or, and this is the first time it appears on the slide, and I told you it would always do worse, idelalisib and rituximab was the other physician's choice option here. But acalabrutinib clearly beating both of those two options with a 62% progression-free survival at 42 months. Now, when we look in this ASCEND study, looking at these two sort of high-risk features, I've already shown you with ibrutinib in the RESONATE study about the IGHV status. If we look at the bottom panel here first, just concentrating on the red and the blue lines at the top, where we're looking at the comparison of mutated IGHV or unmutated IGHV status treated with acalabrutinib, and you can see those red and blue curves are overlapping. So the IGHV status is not affecting the progression-free survival with acalabrutinib, just as it wasn't affecting the outcomes with ibrutinib in the long-term follow-up from the RESONATE study. And then in the top panel, you can see that the P53 is also not affecting outcome with acalabrutinib in this ASCEND study. So whether patients did or didn't have a P53 aberration. Then moving on to another acalabrutinib study in the relapsed refractory study. So we've already heard from Nick about the 6-year follow-up that was presented at ASH of the Elevate-TN, so the Elevate treatment naive study. This is the Elevate-RR, so the Elevate relapsed refractory study. And this is a head-to-head study of acalabrutinib and ibrutinib. And the most important jump out feature here being this hazard ratio of 1. This study demonstrated that acalabrutinib was non-inferior to ibrutinib and they were of equivalent efficacy. Just to note that in this patient population, there was quite a high rate of sort of high risk genomic changes, so particularly deletion 11q and P53 aberrations. And when the patients were separated out according to their del11q or del17p status, again, acalabrutinib and ibrutinib were of equivalent efficacy. So we're comparing the 2 dotted lines at the top first, red for acalabrutinib and blue for ibrutinib, looking at the del11q status, and you can see that the curves overlap. And then the solid red and blue lines, red for acalabrutinib, blue for ibrutinib, looking at the del17p status, and again, the curves overlap. So equivalent efficacy when we divided the patients out according to these high-risk features. But this is where acalabrutinib sort of won in terms of this safety events. So this direct comparison of acalabrutinib with ibrutinib. And so you can see we've kind of got the any grade events in the first 2 columns, and then the 3rd and 4th column are grade 3 events and above. First of all, to point out this feature about headache. Many of you will know this already, but we predict about 1/3 of patients treated with acalabrutinib will develop a headache. You can see that it's about 1/3 of patients of any grade get this headache. If you look in the grade 3 or above events on the right-hand side, it's very, very low level, 1.5% of patients getting a grade 3 headache. So low sort of severity, but definitely a 1/3 of patients getting a headache, which apparently tends to be very caffeine responsive and usually is short term. So just in the first few months of treatment and then seems to spontaneously improve. But when we're thinking about the specific sort of BTKI associated side effects that we've become very used to and cautious about with ibrutinib, so I'm thinking about hypertension, atrial fibrillation and bleeding events, it does seem in this head-to-head study that acalabrutinib is doing better in all 3 of those compared to ibrutinib, so both hypertension, AF and bleeding events. I'm going to move on now to zanubrutinib, so in the relapsed refractory setting, and this data was updated at ASH 2023. So this is the Alpine study. And like the Elevate-RR study that we've just seen, which was a head-to-head direct comparison of acalabrutinib with ibrutinib in the relapsed refractory setting, the Alpine study is a direct head-to-head comparison of ibrutinib with zanubrutinib in the relapsed refractory setting. And this data was first presented at ASH 2022 and then a further year of follow-up updated in ASH just before Christmas. So these are relapsed refractory patients with at least 1 prior line of treatment, but they could not have been exposed to a prior BTK inhibitor. And then a 1-to-1 randomization between zanubrutinib and ibrutinib, continuous treatment until disease progression or toxicity. Nothing too surprising in terms of the patient characteristics. You can see they were treating patients up into their late 80s and even a 90-year-old patient in the zanubrutinib arm. And just a slightly higher sort of incidence of P53 aberrations that we might expect than we might usually expect in treatment naive patients, but these are obviously relapsed patients who may have acquired some mutations. And the key thing to look at here, and this was talked about a lot at ASH 2022, and now this has been sustained with the extra year of follow-up at ASH 2023, is that there seems to be a PFS benefit of zanubrutinib over ibrutinib in this relapse setting. So whereas we saw that acalabrutinib and ibrutinib appeared completely equivalent, there does seem to be a bit of benefit of zanubrutinib over ibrutinib. And in particular, this is played out in these P53 aberrant patients, which I think is really interesting. I've included this slide about complete responses, really not to make any particular point whatsoever about the comparison of ibrutinib or zanubrutinib, but really just as a point specifically about BTK inhibitors. So it's just one little kind of nugget of information, which you may know already or might come as news to you, as just like a little nugget of information that I always have in my head when I'm thinking about the comparison of BTK inhibitors with venetoclax. I kind of think of a BTK inhibitor as being a bit of a snail and venetoclax as being a hare. If we look at this over time, so we're starting on the left from 6 months all the way through to 48 months on the right-hand side, and we're comparing ibrutinib in blue bars with zanubrutinib in green bars. But the majority of these bars are all pale colour. So these are all just representing partial remissions. The number of complete remissions here is actually very low. Even on zanubrutinib at 48 months, the very far right-hand green bar, we're only seeing a 10% CR rate. Now, if you think back to some of the data that Nick has already shown us, where patients are receiving venetoclax-based treatment, we were seeing much higher rates of complete remission and MRD negativity. So it's just quite a different sort of treatment response you get with a continuous BTK inhibitor compared to a venetoclax-based treatment, where we see good disease control with good overall response rates, but not necessarily achieving very deep or complete responses. So that's the reason I included this slide, really is a comparison between BTK inhibitors and venetoclax, rather than to show you anything in particular here about the comparison of ibrutinib and zanubrutinib. So then if we look at the adverse events of special interest in this direct zanubrutinib versus ibrutinib comparison, so you'll remember that when we looked at the Elevate-RR study and we picked out hypertension, bleeding, and AF, acalabrutinib seemed to have lower rates of those 3 major features compared to ibrutinib. Bleeding isn't highlighted here, but if you compare the rates of any grade bleeding in the left, first column on the left with zanubrutinib compared to the 3rd column, any grade bleeding with ibrutinib, you'll see they're basically the same. Similarly, with hypertension, the rates of hypertension between zanubrutinib and ibrutinib, basically the same. And again, with neutropenia, basically the same rates. So we're not actually seeing any improvement in terms of toxicity profile, particularly in bleeding, hypertension, when we're comparing zanubrutinib and ibrutinib. The difference, however, does seem to be in terms of atrial fibrillation, flutter, and other cardiac arrhythmias or significant cardiac events in zanubrutinib compared to ibrutinib. So I think that's just a bit of a kind of key message that certainly sticks in my head when I'm thinking about ibrutinib, acalabrutinib, and zanubrutinib. I do think that acalabrutinib seems to be more tolerable against a wider range of toxicities, including things like arthralgia, bleeding, hypertension, rash, fatigue, so on. But zanubrutinib seems to be quite similar to ibrutinib, but picks out in particular the arrhythmias and the AF as being possibly fewer events compared to ibrutinib. And this just shows us in the Alpine study, the number of events of AF over time being fewer in the zanubrutinib arm in the sort of yellowy green color compared to the blue ibrutinib arm. So I'm going to move on to the BCL2 inhibitors. So in the relapsed refractory setting, we've said we can either give venetoclax as a continuous monotherapy or venetoclax and rituximab as 24 months fixed duration. So different to when we use it in the treatment naive CLL setting, where we give it for 12 months with obinutuzumab. In the relapse setting, we're giving it with rituximab for 2 years. And we can have 6 cycles of rituximab and 2 years in total of venetoclax. So this is from sort of the very early data of venetoclax in the early phase studies published by Stefan Stilgenbauer back in about 2016, where we saw the benefit of venetoclax in really high risk patients, so relapsed refractory patients with P53 aberrations. So you can see here the incidence of P53 mutations, about 3/4 of patients. Because this was quite a few years ago now, only around 11% of patients have been exposed to a prior B-cell receptor inhibitor, such as ibrutinib or idelalisib. Many of these patients had had other chemoimmunotherapy-based regimens previously. And this is just giving an idea of the overall response rates in these very high risk P53 aberrant patients, that we were seeing these high overall response rates. Just note there, just bearing in mind what I just said about the low CR rates with BTKIs, even in this really high risk group, we're seeing a 20% CR rate with a venetoclax monotherapy. And this just shows you some of the progression-free survival and overall survival endpoints in this venetoclax monotherapy study. But we're more likely nowadays in the relapsed refractory setting to use venetoclax and rituximab in combination over this 24-month fixed duration treatment. So this is based on the Murano study, where we can use venetoclax and rituximab in fixed duration for 24 months. We have 6 cycles of rituximab and 24 months of continuous venetoclax after the initial 5-week ramp up. And in the Mirage study, this was randomized to compare with 6 cycles of bendamustine rituximab chemoimmunotherapy. This 7-year outcomes were updated at EHA last year by Arn and Cater. This is a 7-year progression-free survival with a median progression-free survival of 54 months. So sort of 4.5 years in the venetoclax rituximab arm, clearly doing better than the chemoimmunotherapy arm here. When we divide these out into the sort of risk groups that we know about, so the IGHV status and the P53 status, bearing in mind what we've seen with the BTK inhibitors, where the continuous BTK inhibitors don't seem to have such a differential when we apply IGHV status or P53 aberration. You can see here that with venetoclax rituximab, IGHV and P53 disruption do have an impact on outcomes. Excuse me. So we've got here a bit of a summary of the drugs we have available currently and the sort of key data, the key studies and publications that support those drugs. So coming on to the second bit, is there a right or wrong order in which to use them? How do we decide about sequencing? Does it matter which order we use them in? We've already talked about this a bit in the discussion. You know, when we're talking to our patient and thinking about what the right treatment option is, we're going to be thinking about toxicities. Are there comorbidities in the patient that might influence this? Somebody asked the question about a patient who's had a recent MI, and are we going to want to give them a BTK inhibitor, or we're going to avoid that because they're on antiplatelet therapy and they've just had a stent and so on. So there's going to be things related to the patient, things related to the disease in terms of IGHV status and other high-risk features. And then obviously taking into account the patient preference, whether they might want to think about fixed duration or continuous treatment. So all the kind of things we've already mentioned in the treatment naive setting. But in the relapsed refractory setting, probably the most important first question is, what has the patient already had? And when we're thinking, sitting here right now, the potential options that patients might be having right now in the sort of treatment naive setting obviously include I plus V. So in the future, we might be looking at patients who've had I plus V as their first line treatment. They might have had a continuous BTK inhibitor as their frontline treatment. They might have had venetoclax and obinutuzumab. It's possible we're still going to be encountering a handful of patients who have had chemoimmunotherapy as their frontline treatment and are now encountering their first relapse. So what has the patient already had? And then definitely key questions. Why did it stop? So did that treatment they've had before stop because they got to the end of their planned fixed duration treatment? Or did it stop because of progressive disease on the treatment? Or did it stop because of toxicities and side effects and the patient couldn't tolerate the treatment? So I think those are the kind of two really key features. We can then start to think about the data we have to support us in using one of these targeted agents, in what order we use them in and when we can use them one after another. So first of all, if we think about using venetoclax after a BTK inhibitor, we have prospective data to support the use of venetoclax after a BTK inhibitor. So overall, when we're thinking about the data we have to think about sequencing, we don't have these large randomized phase 3 studies. So we don't have as much data to make the treatment decision as we have to sort of support the initial use of venetoclax or BTK inhibitors. We have a combination of some retrospective and some prospective data to support our decisions. So in this study, published initially in the Lancet Oncology and then subsequently updated at UKCLL last year, a study of 127 patients, and this was a non-randomized phase 2 open label study looking at patients who'd had a previous B-cell receptor inhibitor. The majority of them had had previous ibrutinib, but some had had idelalisib, and they were now relapsed and needing another treatment. And essentially, the updated outcomes presented at IWCLL last year demonstrated that venetoclax monotherapy was effective in all of these patients, regardless of their frontline B-cell receptor inhibitor. So we saw some prospective data there for the use of venetoclax in that setting. We have some retrospective real-world data from the UKCLL forum, looking at the outcomes when patients go onto venetoclax when they've progressed on a previous B-cell receptor inhibitor. So looking here at real-world data published by Toby Ayer, where patients were treated with venetoclax after a prior B-cell receptor inhibitor. 2/3 of them, as you can see here, the prior B-cell receptor inhibitor was ibrutinib or another BTKI. About a quarter had had idelalisib, and 10% had had both a brutonal tyrosine kinase inhibitor and idelalisib. In terms of their outcomes, if they progressed on their previous B-cell receptor inhibitor, so the dotted line, then they clearly had worse outcome in terms of progression-free survival compared to the solid line for patients who'd not progressed on their B-cell receptor inhibitor. We have some retrospective data for the use of BTKI after venetoclax. So this was published by Anthony Mato et al. A few years ago, a large international retrospective study, 326 patients. These patients had all been previously treated with venetoclax, and the absolute vast majority of them, so 96%, had had venetoclax in a relapsed refractory setting. So they'd already had other prior lines before they'd even got to venetoclax. And the median number of prior lines of treatment was 3. So these patients had a lot of treatment before they'd even got to venetoclax. 40% of them had never had a BTKI before. And the most common next line of treatment in this study was a BTKI. Now, there's a couple of different things to pick out here. The first thing in this retrospective study is to just look, first of all, in the panels A and C. So if we look in the top panel A, we're looking here at these patients who've had venetoclax, now need retreatment, and they're getting a BTKI, and they've never had a BTKI before. And we can compare that with panel C, in patients who've had venetoclax before, now need another treatment, and are getting a PI3 kinase inhibitor like idelalisib, and they've never had one before. And you can see here clearly that the BTK inhibitor is doing better than the PI3 kinase inhibitor. So another bit of data where the PI3 kinase inhibitor is always doing worse than the other thing on the slide. And so in these post-venetoclax patients, we're always going to be choosing the BTK inhibitor over the PI3 kinase inhibitor. But then important to point out, in patients who had had BTK inhibitors before. So we said a proportion of these patients, because they've been through several lines of treatment before they first got to venetoclax, and some of them had had a BTK inhibitor before they got to venetoclax, and now they need retreatment. So when these patients were retreated and went on to a BTK inhibitor again, the patients who had stopped their BTK inhibitor in the past because of toxicity, so the top line, which is sort of bluey color, clearly did better than those who had to stop their BTK inhibitor in the past because of CLL progression. Can we use the same drug again? So when we're thinking about our targeted agents, if somebody's done well on one before, can we get it out and use it again? We have some prospective data for this. So specifically from the Murano study, they're small to moderate numbers of patients here. So this is the Murano study that you'll remember was the venetoclax and rituximab combination study. 67 patients went on to have progressive disease after venetoclax and rituximab. 32 of those were retreated with venetoclax-based treatment with an overall response rate of 72%. So a pretty decent overall response rate in retreatment in patients who've progressed having been treated with venetoclax before. This study also, it's a very small number of patients, but does also give us some information about BTK inhibitors prospectively after venetoclax, because a prior BTK inhibitor exposure was excluded in the Murano study. So these patients who went on to have treatment with a BTK inhibitor after progressive disease with venetoclax rituximab had not had prior exposure to a BTK inhibitor and had a 100% response rate when they were subsequently treated with BTK inhibitor. A little bit from Captivates. This is obviously looking at the data from ASH 2023, and Nick has presented some of this already because obviously this was a treatment naive study. And what Paolo Ghia presented at ASH 2023 was specifically looking at the 202 patients who'd been treated in the fixed duration of this study. So the Captivate study had a fixed duration cohort and an MRD-driven cohort. And he presented the data at ASH 2023 for 202 patients who had received just 15 cycles of ibrutinib and venetoclax. So the same as what we currently have access to. These were young, fit patients. And of the 53 patients who progressed, you won't be surprised to see that they were enriched for these sort of high-risk genomic features, so P53 aberrations, DEL11Q, unmutated IGHV status, compared to the patients who didn't progress. What was really interesting was that they went on specifically to look to see whether of these patients who had progressed, did they have recognized mutations in BTK or PLC gamma 2, which are recognized mutations known to be associated with resistance to ibrutinib, or mutations in BCL2, which is known to be associated with resistance to venetoclax. And in the 40 patients out of the 52 who progressed, the 40 patients they evaluated, none of them had BTK or PLC gamma 2 mutations identified. There was a low-level subclonal mutation in BCL2 identified in one of the patients of an unknown significance. And when these patients went on to be retreated with ibrutinib-based treatment, then you can see that they had very impressive overall response rates again. So we have this overall response rate, just a very low complete remission rate, as we know occurs with the continuous BTKI. On the left with single agent ibrutinib. And then on the right, some of the patients were retreated with I+V in combination, very small numbers, only 6 patients, but again, a very good overall response rate with a CR rate of about 1/3 of the patients. So the authors concluded when they presented this data at ASH that this first-line fixed duration treatment of I+V may mitigate against the development of the resistance mechanisms which we know can develop when patients are treated with continuous single-agent targeted therapies and can be associated with resistance if we were to consider retreatment again in the future. And that when we use ibrutinib-based retreatment in these patients, we're seeing promising results when patients need treatment again. So that's prospective data about using ibrutinib-based retreatment after I+V. Just a quick little bit of data, and Nick has already sort of alluded to this, that can you change from one BTKI to another? Well, again, this was presented at ASH 2023 about swapping for toxicity. This is a phase 2 study, and this wasn't just CLL, there were other indolent lymphoma patients here, LPL, marginal zone, mantle cell. But essentially, when patients had to stop either ibrutinib or acalabrutinib because of toxicity, and then they were retreated with zanubrutinib, you can see that in the majority of patients, coloured in blue, then the toxicity that had been a problem on the ibrutinib or acalabrutinib did not recur. In a small number of patients, the toxicity did recur, but it was either at a lower grade, the green bits, or at the same grade, the orange bits that they'd experienced before, and never at a higher grade because there's no red bits on the chart. So, possibly unhelpfully, I'm going to conclude that there's no clear right or wrong order. And I think this really comes down to what George was saying before in terms of when we're first talking about treatments with a patient, we're kind of strategizing and thinking about what are we trying to achieve with this particular patient? Where are we going? What duration of response are we trying to achieve at what stage in their treatment? But what we do know, based on a collection of both prospective and retrospective data, is that we can effectively use a BTK inhibitor after venetoclax or vice versa. That we can use venetoclax to retreat in patients who've been previously exposed to venetoclax fixed duration, and that there is evidence from the Captivate data that we can use ibrutinib-based treatment after I+V, bearing in mind that in all of these studies, we're talking about tens of patients, maybe 100 and so patients. We're not talking about large randomized studies. And we know that using an alternative BTKI is an effective and useful strategy if we've had to stop another BTKI because of toxicity. Now, I'm just going to say a little bit about pirtobrutinib because we're in a relapsed CLL talk. Normally, when people show me a picture like this, I completely gloss over and stop concentrating. So I'm going to highlight the important bits in red. If you're a covalent BTKI, then you look like this. You're a yellow and blue blob. So when we're talking about the covalent BTK inhibitors, we're talking about ibrutinib, acalabrutinib, zanubrutinib. And if you want to bind and do your job, then you need to be able to bind to this bit here, C481, and it needs to not be mutated. If you're a non-covalent BTK inhibitor, such as pirtobrutinib, then you look completely different. It doesn't matter whether this bit is mutated because you don't need to bind to it to do your job. So this is about the fact that if you've got a C481S mutation in BTK, which is one of the mutations we know can be acquired, and George has just told us that it can also occur spontaneously in previously untreated patients, which I did not know. But if you've got a mutation C481S, then that is going to have conferred resistance against these covalent BTK inhibitors, but it is not going to have a potential effect on your response to the non-covalent BTK inhibitors because it's not an important bit of the binding site for them to do their job. So over the last 3 ASHs, we've seen data in the Bruin study, looking at pirtobrutinib in a number of lymphomas, but looking particularly useful in CLL. And there was some updated data presented at this ASH. So this is just to give you an idea of what we know already from the early phase Bruin study. In the CLL patients, over 200 patients treated, patients 100% who've had prior BTK inhibitors, a fair number, 40% have had venetoclax, even a bit of CAR-T and allogeneic stem cell transplant chucked in there. But you can see that 40% of the patients have mutations in BTK, which we know confer resistance to the covalent BTK inhibitors. The data that was updated at this ASH was looking at how patients treated with pirtobrutinib did if they'd been exposed to a prior to a So they've all been exposed to a prior covalent BTK inhibitor, but it's whether they've been exposed to venetoclax or another BCL2 inhibitor in the past. We've got the BCL2 inhibitor naive patients on the left, the BCL2 inhibitor exposed patients on the right. And you can see that the patients who are naive to BCL2 inhibitors are actually responding better to pirtobrutinib than the double refractory patients who've previously been exposed to both a covalent BTKI and a BCL2 inhibitor. And I've just brought this up, and George kind of mentioned this a little bit just before we started this talk. And I think this probably will become more important as we learn more about this. This was another abstract presented at ASH 2023, specifically related to pirtobrutinib. And this was talking about the genomic evolution that had been detected in patients who progressed on pirtobrutinib. And patients with progressive disease on pirtobrutinib, we've seen that the C481S mutation, that's a problem for covalent BTK inhibitors, isn't an issue for pirtobrutinib, and they weren't seeing new acquired mutations in C481S frequently at all in patients progressing on pirtobrutinib. But they were seeing different mutations at different sites, L528W and T474I. And we need to think about this, I guess, the question that somebody asked earlier in terms of should we be looking for BTK mutations in all patients. This might become something we need to think about in the future, particularly as we get these non-covalent BTK inhibitors available in the future, hopefully, and how we sequence these. If we give one drug, are we potentially making somebody resistant or leaving the door open to use other BTK inhibitors in the future? So I think that is going to have an impact on sequencing in the future. This is very brief. I can see Renata hovering there, and we're coming to the end. So I've just got a couple of slides really for future possibilities. And this is opening the door for Piers Patton, who's going to talk about trials next week. In terms of future possibilities, Anya Siddiqui presented some data on lyso-cell, CAR T cells and CLL. So these are relapsed refractory patients who've had multiple prior lines of therapy, high-risk patients. You can see that they had a full study population in the left-hand column and 100% patients with BTK progression or venetoclax failure in the right hand. So these double refractory subset of patients, 70 patients in the right-hand column. I just picked out here this sort of 12-month follow-up that in the full study population at 12 months, we've got a sort of 55% progression-free survival. We've basically reached the median progression-free survival at 12 months in the patients who've been double refractory to both BTK inhibitors and venetoclax previously. And this is just a highlight. If we look at the full study population on the left, so 88 patients, and then we look at my little red box on the bottom, 17 of them achieved a complete response. So it's quite low numbers of patients achieving a complete response. If they achieve a complete response in this light blue, they do really well. If they don't, these partial responders, they're clearly doing less well. And then if we look at this next slide, the non-responders in the reddy browny color at the bottom are doing absolutely dreadfully. So you can see this sort of 50% progression-free survival within 6 months. So basically, if you respond to CAR T cells, you're doing very well, but it is just a small group of patients who are achieving this complete response. One slide on new drugs. Definitely opening the door for Piers Patton for next week. BTK degraders will be really interesting to see where these go. There are a couple of different products available already in early phase clinical trials from BeiGene and Nurix, and these are available in the UK already. 43 CLL patients treated so far, many of them double refractory to the BTK inhibitors and the BCL2 inhibitors, and thus far seeing a sort of mixture of partial response and stable disease. So in conclusion, we've just done a quick run through the data for BTK inhibitors in relapsed refractory CLL, just showing in the Elevate-RR study, the equivalent efficacy of acalabrutinib and ibrutinib. That in the Alpine studies, ibrutinib looks at least equivalent, if not possibly better than ibrutinib. In terms of toxicity, in my head, it's very simple. I'm keeping it very simple in my head. Acalabrutinib to me looks just a little bit across the board better than zanubrutinib, which looks better than ibrutinib just in terms of those kind of significant cardiac toxicities and arrhythmias. And we don't seem to see the adverse impact of P53 or IGHV status affecting outcome when we're thinking about continuous BTKIs. Whereas with venetoclax and rituximab in combination relapsed refractory, IGHV and P53 do affect outcome. Sequencing, we've seen that we've got some both retrospective and prospective data to kind of show us that we can use these novel agents or targeted agents one after the other, and we're still seeing responses. But I think we need to think about the mutation profiles that are developing after progression on the different BTK inhibitors and whether this is going to affect what we want to do in the future. And then these future possibilities, more on that in the trials section next week. Thank you very much.
Thank you, Helen. That was amazing. Huge amount of data covered in only 40 minutes and loads of new information. So thank you for that. I think one sort of important point is that whenever we're deciding on a first line treatment, I think it's already we kind of making decision on a second line treatment. And I think that's why we put those two talks together, because I think that's quite important, and just kind of think what. So the patient has got option for absolutely everything. So there are obviously drugs like obinutuzumab we can't use in a second line, but essentially everything else you presented, we can use in a second line. So question to you, ibrutinib. Obviously, we've been using ibrutinib, I think, I believe this year is 10-year anniversary, or was it last year? 10-year anniversary. It's been 10 years since we've been using it. We've got huge amount of data. Yes, we've got head-to-head, 2 studies head-to-head. But are you prescribing any ibrutinib currently to any of your patients? And I mean, is it better for the devil you know? Because obviously we've got 10 years of data. We making that leap assumption that with newer agents, are they really better? Well, we've seen the efficacy, we've seen side effects. What's your thoughts about ibrutinib?
I don't really prescribe ibrutinib anymore in CLL. Obviously, we've got the I+V. That's a separate question, isn't it? That's whether you want to use the I+V in combination. But if I'm thinking about continuous BTK inhibitor monotherapy, then no, I wouldn't choose ibrutinib at all. And I think they're the best of the devil you know. I think we've got lots of experience now with acalabrutinib, and we're seeing quite long-term sort of outcomes now, the published data. You know, we've got years of follow-up now with acalabrutinib. I wouldn't be prescribing ibrutinib really because that toxicity profile. I think we've got better agents that we can use now.
Thank you. George, the question about allo transplant, when would you consider? I mean, obviously, thank you, anonymous attender. The bendamustine, I would say, as Helen said, there is big cross. I think let's get it clear today. There is no place for any chemotherapy, including bendamustine rituximab or chlorambucil obinutuzumab. Even if you think it's a mild, gentle chemo, there is no place for any chemoimmunotherapy in a second line, and there will be no place, especially after FLAIR data, in a front line either. So let's just get this chestnut thing out of the way. So there is no place of chemo. Now, allo.
Wow, Renata, we just told off on the delegates. I'm going to defend them because I think they were asking in the future. Because, you know, I sit there thinking...
in the future. Yes, thank you for that.
And I sit there thinking, right, I'm 55. So 5 years from now, when I retire, and I hand over this big bag of problems to my colleagues who I've just been putting people on BTK, I'm giving this drug, they're all very well. But there is a risk they're going to burn through these treatments. And I remember a few years ago saying, gosh, I can't imagine allografting CLL. And then lo and behold, we did 2 last year. And both of them had gone through everything. They'd done their chemos, they'd done BTK, venetoclax, actually back to BTK, non-covalent BTK. They hadn't done bispecifics. We'd been lining them up for CAR T, didn't get time, and went to allogeneic transplant. One of those has now gone through that and is back on nemtabrutinib in the 003 trial. That drug I don't think featured, may have missed it. But so there are loads of things happening. They're very exciting, but I don't know. I look at those BTK degraders and I'm slightly underwhelmed by the response. And I'm getting myself a little bit anxious that all of a sudden our current SHOs, junior registrars, might be rediscovering chemotherapy, and they'll be saying, they've got these great new drugs. The brilliant advantage is they're not targeted. So they get all these extra mutations because they're not just homing in on one pathway. I say that cynically. Of course I do, because the targeted therapy revolution has been amazing. But allograft, it's going to be there. I think the tone of that question was, come on, guys, if you're 35 and you present and you give them Veno and you put them in a remission, is there not some logic for trying to allograft them? And of course, there are still firm believers around the world. Yet we as CLL doctors, we just can't bear making our patients ill, can we?
I have 2 patients on the go at the minute. I have 2 patients on the go at the minute, one in their 30s, one in their 50s, and both of them I'm having that allogeneic transplant debate. And I think it's impossible not to think about it in a 30-something-year-old. And then
Nicholas is coming in. He's a keen young consultant here.
and a 50-year-old, you know, similarly, I think it's really tricky. So I am talking to both of them about allo, but I think, like you say, George, we don't like making our patients really ill with allo. You know, I can't quite bear to hand them over to my allo team, much as I love them. And similarly, you've mentioned your patient from last year now on nemtabrutinib. I mean, our experience has been they all end up relapsing within a couple of years, and then you pull your new thing out the bag anyway. And then I worry, will we potentially made them ineligible for other things because they've had a prior allogeneic transplant trial-wise, or, you know, what if they die of the toxicity along the way? But I definitely think it's something we that's potentially is still on the table, because
yeah, I think allo became even more attractive because CAR T was disappointing, unless you've got any fantastic way to choose that 30% of patients who do relapse. And I think what we've learned from targeted therapies, that if somebody is not responding to those two targeted therapies, they do really, really badly. So I think in a way, we've seen kind of renaissance of allo for those particularly bad patients. Nick, sorry.
Yeah, I want to echo George's a word about allo. So I have referred also to patients in the last 6 months who've gone through all drugs on the heaven and they've got no further options. So it is becoming, after many years of having both venetoclax and ibrutinib available, a reality for many of our patients, unfortunately. I just a couple of experiences and a couple of messages about allogeneic. We're keen allografters in Nottingham, as you probably all know, so I'm quite big defenders of it. But I've managed to, so 2 experiences. I have now currently an allograft patient who was allografted 10 years ago and relapsed 10 years later, being TP53 aberrant and completely naive to all novel agents. So if you think about what has the allograft given this patient, P53 allograft 10 years ago, it's actually bought him time. So he's now have a relapse CLL, has no GVHD, and has all the treatments available to him. And another patient who was previously refractory to everything, and after allograft, he's been proven to be susceptible to BTK inhibitors again, even though he's progressed on them before. And there's some change in clonal dynamics, and some people who then there might have the emergence of clones that might still be susceptible to BTKs or to BCL2 inhibitors later on after allograft. So it comes to the point I want to make about allografts is basically another line of therapy, and that should be considered as that. It buys people time, and when people don't have any other options, then you might give them a few years of disease-free in order to be able to access new drugs. And this field is moving, so 5 years' time, 3 years' time, 4 years' time, they might have access to all the new drugs, and they just might keep going. And that's has been my experience with allograft. And also, when you try to sell allograft to a CLL patient, again, it's really hard to send the patient with a PS0 to an allograft. And it's important that they know what they're going into. And the figure is a third. So a third of the patients will go into allograft and will be disease-free, GVHD-free survival, probably for a long term. So something to keep in mind when you're thinking about sending your patient to an allograft.
Yeah, Lilia and John, I would like to ask you a question about allograft. Is that, Helen? Sorry, I interrupted you. Did you want to add anything?
The only thing I was going to say was when we're sitting at the start, say you've got a 30-year-old patient, or, you know, somebody where an allo might be on the table at some point, and you're at that very starting point that George was talking about, where we're mapping things out. Does that affect how you start right at the beginning? Because something in my head tells me if we're going to do an allo, you want the patient to be in remission at the time you do your allo. And if you give them a continuous BTKI, you don't get really deep remissions. So while we might typically go to venetoclax and obinutuzumab in our front line, if we're thinking this patient ultimately might be an allogeneic candidate, should we be holding off that venetoclax-based therapy for a later line of treatment so that they're in their best remission at the time they come to their allo? Or do we work on the basis that, fingers crossed, hopefully we'll be able to use a venetoclax retreatment at a later date and get them back into a deep remission then? These are the kind of things that worry me.
Yeah, George or Nick, have you got, that's an interesting point. Anything to comment on that?
I like that philosophical point, and it is difficult. So first observation about BTK, this discussion that with BTKs, there is actually a minority who are doing extremely well. And these are the patients we've stopped. So I just had one the other week, she's complex third line ibrutinib. She's one of my few patients on ibrutinib for 7 years. Then she had a run of ventricular tachycardia, had a collapse. I've stopped it, very stressed about everything. So I've broken my rules and done MRD on her peripheral blood, can't see any CLL at all. CT scan, no lymph nodes. So of course, I'm leaving her off all drugs now. And we all have these patients in our clinics who've gone into remissions, and I've got a few that are now 4 years out from the last time I had a BTK. So although I like your premise, Helen, that keep venetoclax to clean out the marrow, when you're planning so many unknown variables, then you throw in the variable of time. 10 years from now, it might all be very different.
Yeah.
It gets very difficult. And I
I
cut
think
off John as
I think
well.
it just makes sense about using a continuous BTKI just before an allo. It doesn't quite feel like the deep response you want in something if you're building up to an allo. That's the thing that worries me.
I hear that. I hear that.
And maybe this is when you would switch it to ibrutinib rather than just to get those T cells in a better shape, like the using ibrutinib before CAR T. Just the thought. Lilia and John, were you ever, I'm sorry, I feel really awkward to ask you that question, because this is something, obviously, I know you both been through the mill of all therapies. Was the allo ever considered, and what's your attitude to allo?
Maybe if I go first, because I actually had a stem cell transplant back in 1997, but it was an autologous one. It took a big chunk out of my life. On the plus side, it then gave me a period, my longest period of remission. So that was good. The allo one, it's never really been an option because we've always considered other treatments, and having had the autologous one, it didn't feature on my radar, to the best of my patient perspective knowledge.
Yeah, when I had my first line treatment, which was like John some time ago, that was back in 2010. At that point, I was told that if and when I relapsed, it might be an option, but I've never had any more detailed discussion than that. Could I turn the discussion around a little bit and go back to what George's? I know you were doing it slightly tongue in cheek, that young hematologists might eventually come back to chemo as a chemoimmunotherapy as the great new treatment. I'm slightly puzzled why FCR is being disregarded quite so quickly for exactly the reasons you're discussing. I've had FCR and I've had I+V, and one of my big concerns about taking I+V was that I put all my eggs in one basket. What was I going to have next?
Lily, can I answer a little bit back? I know we're pushed for time, because I often throw out really ridiculous things that I shouldn't say. So I guess one of the worries about chemotherapy, and it is a fair statement, that alkylators, so the C in FCR cross-links DNA, and the purine analog replaces a new analog into the DNA. So it works to kill cells by changing the fundamental nature of the DNA. And that's why in some of the data Nick presented, which showed this higher rate, particularly of hematological cancers. And so the fear about giving chemotherapy to younger people is that you've got 30, 40 years mapped ahead of them, and what are you doing in terms of genomic toxicity? And that is possibly to all stem cells, not just hematopoietic. And we've got some data we're submitting from the Hodgkin's world, sort of mapping out stem cell damage from particular chemotherapy drugs. So my sort of slightly provocative comment was, well, when targeted therapies don't work, maybe therapies that are a blanket bomb. It's like your drone targeted thing doesn't work, so send the cluster bombs.
I understand some of that, but shouldn't it also be part of the discussion with the patient community? It's not that was my point, really. Not that I'm a huge advocate of it, but just.
So I definitely agree that also there are people who had FCR 20 years ago and have never returned to CLL, and these people think it's crazy having this discussion. But I think Nick was drawing out that comparison in CLL 13, where the venetoclax obinutuzumab in young people, which, you know, fair play to NICE and NHS England, they let us bring that in to young people in the NHS before we had that data. And again, CLL Support Association, CLL Forum, we lobbied hard for that drug on sort of reverse age discrimination. And now out comes the German data. And look at those mutated IGHVs. So the people who defended FCR are still, they have to look at this data in young people and see those venetoclax and obinutuzumab with such a low relapse rate. Those guys, there must be a decent chance that 20, 30 years from now, quite a chunk of them have never relapsed. So I think the power of our newer therapies, venetoclax based, really are pushing chemo into distance. But for those unlucky people that are relapsing through all our drugs, of course, when we've got a patient who's had ACALA, they've had venetoclax, they've had pirtobrutinib, and they come into our clinic relapsing, we are going to be reaching for bendamustine rituximab or FCR, because we would. It's, you know, you're not going to let somebody die who's fit enough to have chemo, as a final comment. But my comment is really that could be when we've all retired. So we've kind of retired with our chemotherapy experience, and then new people will discover it again.
And can I just say, discussing with a you know, to back to your point, Lilia. So discussing with a patient that's going to go into potentially go into chemotherapy with a new diagnosed or recently diagnosed CLL, who then you're thinking about, you know, side effects, etc., chemotherapy, and then having a big discussion and sort of an informed discussion about the risk of secondary cancers is really difficult. I personally find it very difficult, not because you can't have it, is because it you know, it's either underplayed or overplayed, and it's really difficult to keep it fairly balanced, and it's difficult to to get the right tone with patients into what the actual risk of secondary malignancies is, and the secondary malignancies can be as easy as a basal cell carcinoma and as tragic as a secondary AML, which is completely refractory to therapy. And once you've seen that, and then from our perspective, doctor perspective, once you've seen that once, you're quite scarred in many ways, because you then, you know,
it's an experience of one, but it's a very strong experience of one. I mean, basically, you know, that anecdote, yes, I mean, you're absolutely right. Once you go through this, and I had a unfortunate experience going through somebody, you know, with having those problems. Yeah, I mean, it's just truly experience how you think about those things. I realize we passed time. I think it's very important we answer those questions, but I just want to remind you all, whoever joined us today, so thank you. And if you could do the exit polls, because it really helps us to organize another course, and which could be very useful for you, and how we can improve it. So very quick question, maybe Helen, if you've got somebody stable on ibrutinib, no toxicity, and you've got obviously ACALA and ZANU, they've got ongoing CR, rock that boat? Change it? Change it.
I probably wouldn't rock the boat. I mean, officially, you're not allowed to rock the boat, are you? Because they have to have a reason to stop there. You'd have to make up some toxicity, because you can only change them if they've got some toxicity, and that's why you're stopping the ibrutinib and moving on to something else. So you'd have to fudge it on the piece of paper and make up some toxicity to change them. Personally, I wouldn't, unless, you know, unless the patient is expressing to me that they're worried about toxicity, or they're concerned about being on the ibrutinib. I wouldn't if they've been completely toxicity free and they're getting on with it fine. Yeah.
And Nick, BTKI with significant cardiac disease, safe to use? I mean, obviously there is the AZ is about to start the study about sort of choosing specifically patients with cardiac, but currently, what would you do?
Well, the first thing to say about cardiac toxicity is really important to really know exactly what cardiac toxicity is. It's different if the patient has hypertension, whether they have ischemic heart disease, or whether they have heart failure. For me personally, hypertension is manageable and should be managed appropriately. And if you have controlled hypertension, you are probably okay from that point of view. And there's data that shows that actually the poorly controlled hypertension that has been driven by the BTK is actually what is driving the high risk of cardiovascular problems.
And if I could just quickly jump, I think it's so important to empower our patients and just give, I think that's what pandemic did, one of the good things, because they don't come to clinic anymore. And I think it's important to tell them, get that sphygmanometer, measure that blood pressure, and give them, give them the choice. And they need to sort of, it's being accountable for your health. It's not all down to us. And I think it's so important. Sorry to jump in.
Yeah. Second one is heart failure. To me, heart failure is a no-no, because then you're very likely to damage that person's life quality with, risk of sort of heart failure exacerbations, etc. And then ischemic heart disease depends on a big concern, because these people have fertile ground for arrhythmias, and then you will be probably this is the group of patients that would have the highest risk theoretically of sort of ventricular arrhythmias, etc. And then AF, again, manageable. I think the zanubrutinib has shown that probably has the least amount of AF compared to the others too, but the numbers are very small, so it's very difficult to draw these conclusions from cross-trial comparison with an event that has an incidence below 10%. So again, there's what numbers show, but you cannot be too categorical about it. So those would be my suggestions.
And maybe parting question to George, just very quickly, were you convinced with that zanubrutinib is the treatment of choice for P53 deleted patients and mutated?
So I think you've just got to be quite careful. These trials are different eras, slightly different things. If you want to cross-compare trials, you have to remember the headline PFS figures are pretty equal between them. I think choose your BTK based on what you feel about. Nick didn't get himself drawn into them. There's similar efficacy, there's similar toxicity. As I always say, ACALA, we're so familiar with it. It's Beijing's job is to try and make us feel as familiar and comfortable with zanubrutinib. I think there are very few instances where you're right or wrong. In the private clinic, Nick hinted at this. I think this is a real shame that we can't get ACALA plus obinutuzumab in the NHS. I think that is influencing private prescribing.
Although I've got to say, I've had a chat with AZ and they're promising, but whether it's happened, that they're going to take AO to NICE. So watch this space.
Amazing.
Fingers
well done.
crossed. Fingers crossed. So on that note, thank you to my co-chair, George. Thank you to speakers, Helen and Nick. And thank you to our fantastic patient representative, Lilia and John. And so thank you all. Have a good night and I'll see you next week.